I'm John Strum, and this is Real Talk MS. It's October 15th, and we have a lot to talk about. Today marks the first day of open enrollment, the one opportunity we get each year to make changes to our health insurance coverage. And while it's always important to understand your options, if you're one of the 25% of the people living with MS who get their coverage through Medicare, it's especially important that you review your drug coverage for 2025 to make sure that you're enrolled in the Medicare Part D plan that's best for you. Joining me to help us decipher those changes and navigate through the sometimes confusing world of health insurance is pharmacist and Senior Director of Clinical Resources and Programming at the National MS Society, Sarah Anderson. But before we get to my conversation with Sarah, there are a few other things that you should know about. Myelin repair, or remyelination, holds the promise of restoring function that's been lost due to MS. And today, myelin repair is clearly on the front burner of MS research. Our bodies have the natural ability to repair myelin, but it's been observed among people with MS, and actually everyone as we age, that this ability to self-repair becomes less and less effective. So it's worth noting that a research team at the University of Edinburgh analyzed a type of cell in our brain called oligodendrocyte progenitor cells, or OPCs. Now remember that very long name for these cells because it becomes important in a minute. These OPCs normally transform into oligodendrocytes. These are the cells that produce myelin. Now, the researchers also observed that something in MS lesions was sending out what we'll call anti-repair signals, which stopped those oligodendrocytes from producing myelin. Using a technique called CRISPR, the research team edited a small section of DNA in lab-grown human oligodendrocyte progenitor cells to program them to ignore those anti-repair signals. Then they transplanted these gene-edited OPCs into mouse brains, and the team observed that the OPCs transformed into oligodendrocytes and proceeded to repair damaged myelin around the nerves in the central nervous system. Now, this is where I insert my standard disclaimer that there is a very big difference between mouse brains and human brains. Nonetheless, this is encouraging news. The next step for the research team is to determine whether they can eliminate the need for transplanting these cells and instead directly edit the cells in humans, bringing us a step closer to gene therapy that would effectively promote remyelination. You can be sure we'll be keeping an eye out for updates as this work progresses. In the meantime, if you'd like to review the details of this study, you'll find a link in today's show notes. MS affects women almost 3 times as often as it affects men. So if there was a gender bias in MS care, you'd expect that there would be a greater understanding of how MS impacts women and more clearly defined best practices for treating women with MS. But just because something seems like it should be obvious doesn't necessarily make it true. In research presented last month at ECTRIMS, French researchers showed that women with MS were routinely undertreated compared to their male counterparts. The research team analyzed the French MS registry of 22,657 patients with relapsing MS and looked at treatment differences between men and women from 1997 to 2022. As you might expect, 74% of these patients were women and 26% were men. During an average follow-up period of 11.5 years, the researchers found that women had a significantly lower probability of receiving any disease-modifying treatment. And women were even less likely to receive any of the so-called high-efficacy disease-modifying therapies. The gender gap in MS treatment did not vary much due to age, but it's quite possible that the reason for what appears to be undertreatment could be tied to family planning and pregnancy, which would motivate a neurologist to make a change in a woman's care, but that change should not be in place forever. Whatever the cause, this therapeutic inertia highlights the importance of shared decision-making and self-advocacy. If you're satisfied allowing your neurologist's voice to be the only voice in determining your MS treatment plan, then you have to accept the outcome of that plan. If you're listening to this podcast, I'm willing to bet you already appreciate your role in determining your care with your neurologist. Every good healthcare provider understands that when a patient is a partner and a treatment plan is a result of shared decision-making, adherence to that plan goes way up, leading to the best possible outcome for that patient. I'm hopeful that as researchers continue to increase their focus on MS and women's health in general, the results of this survey will become the exception and not the norm. Another study from France indicates that people with MS have a 6% higher risk of developing any type of cancer compared to people who don't have MS. Researchers also found that people with MS had an even higher risk for developing some cancers and a lower risk for other cancers. Risks were higher specifically for bladder cancer, brain cancer, and cervical cancer, and risks were lower for prostate cancer, breast cancer, and colorectal cancer. In this study, the researchers analyzed data from 2012 to 2021 in the French National Healthcare Database. In this database, they identified 140,649 people with MS, and they matched them based on age, sex, residence, insurance plan, and when they entered the database, with 562,596 healthy controls. These were people who didn't have MS. Everyone in the study had been cancer-free for 3 years preceding the study. About 71% of the study participants were women. The mean age at the beginning of the study was 47, and participants were followed for just over 7.5 years. Interestingly, after stratification by sex, the study showed that the overall higher risk of cancer was only present in women. But before you begin pondering whether you might be at an increased risk of cancer, remember that people with MS regularly undergo more medical tests than people who don't have MS. As one of the study's co-authors, Professor Emmanuel Leray, pointed out, one of the reasons that people with MS might appear to be at higher risk for brain cancer is that most people with MS get regular MRI exams, which could reveal brain cancer even before any symptoms were to develop. Professor Leray also pointed out that frequent urinary tract infections, combined with the use of immunosuppressant drugs, might explain that increase in bladder cancer among people with MS. And it's also important to mention that the database used in this study did not account for lifestyle factors like smoking or drinking, which could have a significant effect on whether someone is more likely to develop cancer. So while we can file the results of this study under interesting, I'm not ready to call it alarming. We'll need better data before we get that excited. If you'd like to review the details of this study, you'll find that link in today's show notes. There's a mountain of evidence that demonstrates people with MS benefit from physical activity, but sometimes there can be obstacles to participating in physical activity. The cost of AFOs, orthotics, bicycles, even physical therapy itself isn't always covered by insurance. Recently, I talked with Dawn Shotland. Dawn is an avid runner who lives with MS, and when she herself ran into some of these obstacles, she decided to do something about it. So if the cost of participating in physical activity is getting in your way, Dawn may have some good news to share. In a moment, you'll meet the founder of In My Running Shoes, Dawn Shotland. By now, if you're a regular listener, you know that I love introducing the Real Talk MS listener community to folks who I consider to be difference makers. My guest today is Dawn Shotland, and Dawn certainly qualifies as someone who's making a difference for people living with MS. Welcome to the podcast, Dawn.
Thank you. Thank you for having me. I'm really excited to be here.
Well, let me start with at the beginning, I suppose. When were you diagnosed with MS?
I was diagnosed 25 years ago with MS. So I've been living over half my life with multiple sclerosis. And, I really consider myself to be an MS thriver because at my diagnosis, my doctor was very focused on the negative. And she told me that I would never be able to go to the beach or take a hot shower or work out for more than 30 minutes. And I'm incredibly proud to say 25 years later, I do all three of those things and I do them very well.
Well, congratulations on proving that doctor wrong.
Thank you.
Based upon what we're about to talk about, I'm assuming you're an avid runner. Do I have that right?
You are absolutely right about that. I have run 16 marathons and I've run over 30 half marathons. And for me, running became a way of managing MS and feeling empowered and feeling in control of my body. And it worked for me for a very, very long time until one day I started experiencing MS-related drop foot. And when that happened, it was devastating. It took running away from me. It took a lot of my identity away from me, and it pulled me out of a lot of my social circles because a lot of my friends were runners, and that's what we were doing in our spare time. So for me, it was really devastating when that happened. And I spent a lot of time and a lot of money trying to find ways to keep running. So I went through a lot of different AFOs, which are ankle foot orthostasis, which are braces that help keep your foot in a neutral position so that you don't scrape or have drop foot. And most recently, I'm experimenting with an FES, which is a functional electrical stimulation device to help run. And I'm proud to say I still run today. I figured it out. I have solutions. But the path to get there was time consuming and really expensive for me. Insurance covers some things, but not everything. So there were quite a lot of out-of-pocket expenses. And that's really what motivated me to start a charity called In My Running Shoes.
Which brings me to my very next question. Tell me what In My Running Shoes is all about and how you came to start it.
Yeah, it was just out of my own frustration with having MS-related drop foot and just the limited amount of resources that were out there. Not only is it expensive for a device to help you combat drop foot, at some point I was actually denied physical therapy because my insurance company decided that I couldn't benefit from it anymore. So that got expensive for me. So I founded In My Running Shoes. Our mission is to provide assistance to people with chronic illnesses, MS and other illnesses who want to stay active but need a little financial support to do so. So we write grants to people whose active is a lot of different things. Like for me, my active is running, but for other people, it can be walking, biking, yoga, hiking, strength training, swimming, whatever, and somebody who needs some assistance, some adaptive equipment that isn't covered by insurance. And they need a little financial assistance to get that and to stay active and to stay engaged in their communities.
So what types of equipment or services will an In My Running Shoes grant fund?
Yeah, we're pretty broad. So we really encourage people with any ideas to come to us. But where we've kind of been focused over the past few years is AFOs, the FES devices, the functional electrical stimulation devices, bicycles, electric trikes, any sort of adaptive bicycles, physical therapy, whether it's your co-payments from that, or if you're getting denied from insurance altogether, but you still need that help, or any other sort of adaptive physical fitness equipment that you might need.
How does someone go about applying for a grant from In My Running Shoes?
Yeah, we have a grant process. And if you go to our website, it's www.inmyrunningshoes.org/application. We have an application there online, and we need a note from a doctor just stating that you have a chronic illness and your date of diagnosis. And you just need to tell us a little bit about what you need support with, what your goals are fitness-wise, and how much funding you're looking for. And then our board will evaluate that and come back to you.
Well, we'll be sure to include that link to your website in today's show notes. I couldn't agree more with you when you talked about how, for you, running became a really empowering activity. I think that is true for everyone who finds their physical outlet, the thing that speaks to them, that allows them to use their bodies in a way that they benefit from in so many ways, not just physically, but psychologically, emotionally, every other way. So this is important. I want to thank you for seeing a problem that affects so many people living with MS and then stepping in to solve it. And thanks so much for talking with me today.
Thank you for having me.
Elizabeth Jamieson is an extraordinary artist who lives with progressive MS. Since being diagnosed with multiple sclerosis, Elizabeth has transformed her MRI scans into remarkable and provocative images that challenge how we view the brain, disability, and illness itself. Elizabeth's work is part of the permanent collections at the National Institutes of Health, the Multiple Sclerosis Center at Yale University, the Shepherd Center in Atlanta, the John Paul II MS Rehabilitation Center in Poland, the Center for Brain Science at Harvard University, the MS Clinic at the University of California, San Francisco, and many, many more venues throughout the world. Elizabeth is also an outspoken disability advocate. Her thought-provoking op-ed pieces have appeared in the San Francisco Chronicle, Washington Post, and the New York Times. Now, in collaboration with the Positive Exposure Gallery, Elizabeth's work will be featured in an exhibition titled An Intimate Journey. The Positive Exposure Gallery is located at 14 East 109th Street in New York City, and the exhibition runs from October 19th to November 24th. If you're going to be in or around New York this Saturday, October 19th, the opening reception is from 3 to 6 p.m., and I can't imagine a better way to spend a Saturday afternoon than taking in Elizabeth Jamieson's remarkable work. While we're talking about smart ways to spend your time, if you're one of the 250,000 people with MS who receive their health insurance through Medicare, I'll remind you that open enrollment begins today. And this year, there are some real changes to pay attention to. In a moment, my guest Sarah Anderson will join us to walk us through what those changes are and how you may want to consider the new benefits that are coming your way. Open enrollment is the one opportunity you get each year to make changes to your health insurance coverage. So it's especially important to understand your options and enroll in the health insurance plan that offers the best coverage for your needs at the lowest possible cost. And if you're on Medicare, there are big changes coming in 2025. That's why I'm very glad that joining me to help us decipher those changes and navigate through the sometimes confusing world of health insurance is Sarah Anderson. Sarah is a pharmacist and Senior Director of Clinical Resources and Programming at the National MS Society. Welcome to the podcast, Sarah.
Thanks, John. Happy to be here.
I find the best place to start most conversations is at the beginning. And with that in mind, tell us, what are the main sources of health insurance?
Yes, the main sources of health insurance here in the United States are employer-sponsored plans, government programs such as Medicare and Medicaid, and individual and family business plans.
What kinds of things should people be considering when they choose a health plan? And what specific considerations should people living with MS be thinking about?
Yeah, so when choosing a health plan, people should consider factors like their current and anticipated health needs, the plan's network of providers, and whether or not their current healthcare team and list of providers are considered in network, monthly premiums, deductibles, co-pays, out-of-pocket maximums, prescription drug coverage. Essentially, people would want to be balancing the cost of the plan with the level of coverage that really best suits their individual healthcare needs.
Well, I'm glad you mentioned how important it is to be sure that the providers you choose are part of your network with any given plan, and that the medications you are taking are also covered. How does someone go about finding that information?
Yeah, so people can search for their providers on the health plan website that they're researching to determine whether their specific providers are considered in network for any given plan. People can also call the insurance plan provider to find out whether the plans they're considering covers their medications. Formularies, which are list of covered medications, are oftentimes also posted online on the plan's website, but it can be kind of tricky to navigate the various list of covered medications that can be found on the website, and they're always constantly being updated. So calling the health plan themselves could be your best bet to figuring that out. Also, be sure to ask about co-pays or co-insurance for filling and refilling prescriptions. Also, to compare Medicare plans specifically, you can go to Medicare.gov, and they have a health plan comparison tool that one can utilize in their research.
A moment ago, I mentioned that open enrollment is a special one-time only time of year for making changes to your health insurance coverage. What exactly is open enrollment, and why is it so important?
Yes, so open enrollment is for the health insurance marketplace is the period from November 1st of 2024 to January 15th of 2025. And for Medicare plans specifically, open enrollment is October 15th of 2024 through December 7th of 2024. So changes made during this period will take effect on January 1st of 2025. And during open enrollment, Medicare beneficiaries can switch between Medicare Advantage plans or switch from original Medicare to a Medicare Advantage plan or vice versa. They can choose or change Medicare Part D prescription drug plans. They can add or drop drug coverage. And then some reasons to consider changing your plan during open enrollment include if you've had a significant change in health status recently, if you've had a significant increase in premiums over the past year, if you've had an increase in out-of-pocket costs for current medications, if you are moving to a new state or zip code, if your old plan has been canceled, or if your healthcare team is no longer included in your plan's network.
Thanks to the Inflation Reduction Act, Medicare will offer two new benefits starting in 2025 that will be of special interest to people with MS. First, Medicare participants won't have to pay more than $2,000 per year out of pocket for their Part D drugs. And second is the Medicare prescription payment plan. Can you tell us about these two changes for the better?
Sure, yes. So in 2025, everyone enrolled in Medicare prescription drug coverage Part D plans, which include Medicare Advantage Part D plans, as well as original Medicare Part D plans, will have their out-of-pocket costs capped at $2,000. And the Medicare prescription payment plan, which is a new offering for 2025, allows you to spread out your out-of-pocket costs for Medicare Part D drugs into monthly payments, making it easier to manage high drug costs and stick to your treatment plan. So Medicare Part D drugs would include those that you take at home, so oral medications, self-injectable medications, anything that you take yourself at home. Medications that aren't covered under Medicare Part D and what would be considered covered under Medicare Part D would be those medications that you get, say, at an infusion center, a hospital, or those that are administered by a healthcare professional in a clinic setting.
Two pretty outstanding benefits. The one, the $2,000 per year out-of-pocket cap is quite an adjustment from what used to be a $6,000 per year cap. So that saves every individual on Medicare potentially thousands of dollars. And the prescription payment plan, while it doesn't reduce the cost of those prescription drugs, it does smooth out your payments so you aren't hammered when you have to pay your copay for your January medication. Am I getting that right?
That's correct. Exactly. So, right, instead of going to the pharmacy to pick up your prescription in January and paying the total cost of that prescription up front that day, you can sign up for the Medicare prescription payment plan, which then allows your health plan to send you an invoice or bill you on a monthly basis in order to spread out that cost over the remaining months of the year. And so, yep, that is exactly correct.
I know you just explained this a moment ago, but it's important, and I know people sometimes get confused. I'm wondering if you wouldn't mind sort of reviewing the difference once again between Medicare Part B or Medicare Part D. Someone's specific MS treatment may fall in either of these two parts depending on how that treatment is being delivered.
Yes. Yep. I'm happy to. So Medicare Part D covers most medications that you take at home, which would include oral pills and self-injectable medications. So things like oral and self-injectable disease-modifying therapies that people may be taking for their MS. And then Part B generally covers those medications that a person receives at a doctor's office, hospital, or infusion center. So the infusible disease-modifying therapies for MS, for example, would be covered under Part B.
So where can someone learn more about this Medicare prescription payment plan or the $2,000 cap on out-of-pocket costs? And where can they or who can they turn to if they need some assistance in figuring it out for themselves?
Yeah, so more information on the new plan and on the $2,000 out-of-pocket cap can be found on our National MS Society website. If you search Medicare, it will take you to the webpage that has additional information on this topic. You also can go to medicare.gov. That's also a great resource that has additional information where you can learn more. And then if you would like to receive some assistance in kind of talking through and walking through some of your options, please feel free to go ahead and contact our MS navigators here at the National MS Society. And again, if you search on our website, Navigator, you'll be taken to a dedicated Navigator webpage that has all their contact information listed on there.
Well, Sarah Anderson, I'm very glad you came bearing good news today. I want to thank you for all you do to help improve the quality of life for people affected by MS. And thanks so much for talking with me today.
Yeah, thanks for having me on, John. I appreciate it.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/372. You'll find that link in today's show notes so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.